About this last disorder. Last disorder. Amyotrophic lateral sclerosis. You heard of multiple sclerosis. Here again, with these individuals, there's some type of, the nerves are in a degenerative process where the innervation to muscle groups is affected. Question.
The recorder's still on? I mean, did you guys turn them off or no?
I didn't.
Okay, good, fine.
Yeah, I didn't say anything that's on there that you can pick up. Okay. Okay. This is a condition where there's sclerosis, so there's not nerve innervation to muscle groups. Again. Okay. The difference between Lou Gehrig's disease and MS is that with MS, what we notice is, what were some beginning signs? Visual changes. With this, it's a progressive disorder of atrophy. With MS, there was spasticity, again, spasticity, visual changes, but with this disorder, it's progressive degenerative disease that involves the motor sensor system. That being said, there's atrophy, not tremors like MS. There's atrophy of hands, forearms, and legs, and it results in paralysis and eventual death. This is not self-limiting. This disorder there'll be degeneration, and the person will eventually have respiratory, acute respiratory failure. Paralysis, then death within 2 to 6 years, depending on the immune system of this person and the resilience of this person that they had before they acquired disorder. Again, it is not self-limiting. It is progressive, yes.
This is probably a stupid question, but when you say it's not self-limiting,
Meaning that they will never have a relapsing phase.
okay.
It'll keep going.
So I'm like, it seems self-limiting. I get it.
Yeah. So these people have the atrophy. It begins in the hands, forearms, and legs. Different from Guillain-Barré, where it's ascending. Remember? It's ascending from the legs, moves up. The body system you need to be more acutely assessing is respiratory in stages, because that person, these individuals, even though it began in the hands and legs, when it reaches respiratory, in the event that it does, the intercostal muscles are not energized, not getting the nerve impulse, and they lose the ability to breathe. Question.
Does it always result, like, I'm thinking of Stephen Hawking and how he's had this, where, like,
Who?
Stephen Hawking,
Uh-huh.
how has he lived with this for, like, 30 years or whatever?
Does he have money?
Yeah.
He's taking experimental medications, different things to enhance.
Okay, so if they're, like, if they're, like, intubated or can breathe on their own, that's pretty much.
Because you're supporting. Progressive weakness and atrophy of the muscles, arms, and legs. They may have slurred speech. That's similar to the MS, but different, because MS has different symptoms initially. If you were asked the differentiation between Lou Gehrig's and MS, what happens is in the early symptoms, there's visual changes with MS. With Lou Gehrig's, it's the hands, the legs, arms. Remember, in MS, you have slurred speech. In Lou Gehrig's, you have slurred speech and difficulty swallowing. So the care is going to be similar. There was fatigue with MS. We have tongue atrophy. Did we have tongue atrophy in MS? Twitching of the face. Do we have twitching of the face with MS?
No.
Where was the tremoring in the hands? Okay. So they're a safety risk. You're going to do the same thing with foods and liquids as you did with MS. You might have to use thicket. You might, the soft foods. You want to prevent any aspiration of food. You want to promote the autonomy of the person, of what they can do. But this disorder is not self-limiting. It just goes degrading. So eventually, you need to be honest with the family member and the patient. If the patient and the family member says to you, will I eventually recover from this? You need to say, not say, oh yeah, everybody dies or something like that. You want to say something to the effect that this is a degrading disorder. Each person is different. Your progression through this disorder may be anywhere from 2 to 6 years, maybe even longer with new medications on the horizon. But the thing about it is, you don't need to say that they'll be cured. You need to be honest. Provide measures for muscle weakness and dysphagia. So what kind of exercises are we going to do with this person since they have atrophy? What kind of exercises are we going to do? Passive or active? Okay.
I guess both, depending on what stage.
Can they actively do anything? You're assisting them for their level of function. So you want to do, if they're in a phase where they can actively do something, you would have them do per their level of performance. But in end stages, you know that you need to assist so that they don't get contractures and there's atrophy that's set in those muscles. You need to do exercises with them, for them, assist them. So that's passive exercise. If they need ventilator support in the hospital, if they're in an exacerbated situation, you would do those nursing measures there. But before they ever need a ventilator, how would you know this person had respiratory distress? How would you know they're going into respiratory distress? You guys know this. The pattern of breathing would change. They're short of breath. They're not having chest rise as readily as they had before. Huh? The color.
Dusky.
Did you say dusky?
Dusky.
The skin, if they're not getting that oxidation, there would be a change in the color of the skin. They may be a little ashen. Cyanosis is a late sign. Okay, so you want to be able to do that. So you're doing a whole total assessment on this person. Provide independence as long as possible. Remember I said, if these people could do active exercises, let them do that. As they progress in the degrading of the disorder, you would then do some passive exercises. And prevent complications of immobility. You know those complications of immobility. Respiratory insult is where they're not breathing deep enough, or they stop breathing and need some type of ventilator support. If they're confused because of not getting enough oxygenation, remember in the late stages it's respiratory that is the problem because the intercostal muscles are not here. The nerve innervations in those are not there. You want to assess respiratory status, the chest rise and fall. You want to look at the pattern of breathing. You want to give O2 support if need be, if they're not ventilated already. As far as GI, those basic things. They're low motility, and they're high risk for constipation, so you want to prevent that. You know dietary-wise what you do there. You want to encourage fluids. You're going to help them with their exercises. You're going to, if they can be wheelchair, transferred to a wheelchair, you would pick them up, having gravity help with food passage. And also, you would also have these individuals, if they're not to the point where They sense that they know when they need to go to the bathroom for urination or bowel. You keep them on a pattern. If not, you might have to catheterize them because you don't want that bladder distension, which can cause more discomfort to the patient. And prevent complications of immobility in that you want to look at all bony prominences, if there's any bony prominences, and you want to prevent any pressured areas. So all of that immobility issue there. Okay, now, what I want you to do is write down these things, and we'll go one by one. Eyes. We're going to review conjunctivitis. We're going to review cataracts. We're going to review detached retina, glaucoma. Ear. We're going to talk about otitis externa, swimmer's ear. Otitis externa, swimmer's ear. We're going to talk about otitis media. And we're going to talk about Meniere's. Next, headaches will not be on this, will not be covered on this exam, but we went over it. Remember when Karen got up here and had her migraine? Okay. Seizures. Parkinson's. Alzheimer's. We talked about CDA, but we're probably only going to have a couple of questions on that. Remember I tell you, and I'll tell you where to centralize. Spinal cord injury. Then today, or last week, we had multiple myasthenia gravis. Put NG, myasthenia gravis. Today we had MS, multiple sclerosis. We just talked about Lou Gehrig's disease. Guillain-Barré. And then the two cranial nerve disorders is Bell's palsy, which is cranial nerve number 7, and trigeminal neuralgia, cranial nerve number 5.
Can you say those last?
Bell's palsy, cranial nerve number 7. Trigeminal neuralgia, cranial nerve number 5. We talked about several meds, but these are the meds you need to know. Solumetrol. And what is solumetrol?
Steroid.
Your anticonvulsant, dilantin integratol. Dilantin integratol. And also put there that they can be used for people who are in a neuralgic type situation. Neuralgia, we can give these Tegretol and dilantin. Also, we talked about Tensilon. And we talked about, as a group, we talked about meds like Mestinon, which are your meds given to decrease the symptom of myasthenia gravis. Okay, let's get into this. Okay, starting with conjunctivitis, highly these individuals usually had it it's transferred as a result of people sharing mascara, people sharing pillows. It can be viral, it can be bacterial, it can be fungal. Bacterial, viral, or fungal. You would not give a antibiotic to a viral condition. You would not give an antibiotic for a viral eye condition of conjunctivitis. What are some things you need to do as a nurse? You need to make sure that this person does not go to school when they're in the acute phase of this disorder, or go to work, which is highly contagious. The thing about it is people will need eye drops placed in. The eye drops are placed in the conjunctiva, not on the middle of the eye, in the conjunctiva. Ointments are put in the conjunctiva, sac. Okay. Once a person is over this disorder from the antimicrobial creams or drops they're getting, the person can get this disorder again. To decrease the transmission of this disorder, hand washing, the person not being exposed to others who do not have the disorder. Okay. Next we talked about, yes.
You said with the eye drops and conjunctiva, is that like the inner part of the eye right
Okay, conjunctiva. Okay, the sac right in here.
here? Okay.
Anyway, then what's next disorder? Cataracts. Cataracts and detached retina are not painful. What is the systemic disorder that predisposes a person to cataracts? A, diabetes. What is cataracts? A film over the eye. So the visual acuity is diminished. Visual acuity is diminished. The thing with these individuals, the surgical need is removal of that cataract. Can a person get cataracts again? Yes. So, pertinent thing you need to tell a person is if the diabetes is the precursor, they found that caused their the cataract to occur. They need to manage their diabetes so that they don't have the occurrence of the cataract. So visual acuity is good. Detached retina can be of two ways: floaters or spots in the visual field, or they just have a shade that comes over their visual field. It's spontaneous. It's not painful. The thing about it is there's a surgery to correct it. We didn't go into that, but just know it's surgery to correct it. If a person has eye surgery relative to cataracts and detached retina, there are things you need to teach a person to prevent intraocular pressure. They need to avoid sneezing, coughing, straining. So if they're straining, get something for that constipation. Okay? It's not the time to pick up those grandchildren because that increases intraocular pressure. And other daily activities increases intraocular pressure too. And we won't go there. Okay. Next, these individuals individuals, you need them, especially with cataracts, to wear a patch over the affected eye, especially at night, to protect that eye.
For cataract and for cataract?
Yeah, it would be both. There may be some eye drops they need to have, anti-infective eye drops also. So a pertinent question might be, what would a person demonstrate, you've done your teaching post-op relative to care of a person who's had an eye surgery. What of the following will the person do that would alert you to their understanding? They would make sure that they cover the eyes with a patch, report any sneezing or coughing or any constipation. That is not the time that they will pick up their grandchildren. On the flip side, what of the following things will the patient do that would alert you to the fact they understood your teaching? It might be one response. So it might be all of the above or one response. What's the next disorder?
Glaucoma.
Glaucoma. Central vision or peripheral vision is affected?
Central.
Peripheral. These people have problems with vision in the periphery out here because the fluid builds up in the aqueous humor. Aqueous humor. What do we do about that? With these individuals, they do tonometry pressure. When they go for their eye exam, they use a tonometry to check the pressure in the eye. These individuals are on miotic eye drops. Miotic. You want the drainage of that fluid. Miotic. An example of a miotic is pilocarpine. Pilocarpine. Or Timolol. Because they have a pupillar constriction and thus aid in drainage of the aqueous humor. Because glaucoma is that buildup of that fluid, you want that fluid as well. Miotic.
Tonometry pressure in the eyes with a puff of air.
This is a puff of air. Now, with these individuals, what other disorders would cause for the buildup of, let me ask this question. If they have buildup of fluid in the eye, what would cause the maintaining of the buildup of fluid in that eye? Hypertension. So, dietary-wise, what would you tell them to avoid? Anything that would high salt content, so a low sodium diet.
We don't need to know macular degeneration.
Macular?
Yeah.
Okay, tell me. Is
I
it
don't
central or peripheral?
It's central.
Who's usually the age group that is associated with?
Oh.
Older people. What is it associated with activity that they do?
Gotta be careful with the question.
Huh? Okay, macular degeneration, it's related to the elderly, but what is the condition I'm talking about? Too much sun exposure.
Oh.
Too much sun exposure, but predominantly it's age related. It's a degenerative change, macular degeneration, where the central vision is affected. That
Do you need to know it?
somewhere around the line you're gonna need to know it. But basically, what are some things that you would know psychosocially might be a problem for these people if they have macular degeneration?
Right.
Loss of vision.
Loss of independence. They can't see their faces of their family members. Psychosocial issues. Okay. So, again, is it a mydriatic or a miotic that you get there?
Wow.
Miotic. All right. What's the next disorder? Ear. Swimming here. Someone goes swimming. What are some things that would prevent the water getting into the ear in the first place?
The pressure, the water pressure.
The water pressure, you put maybe some earplugs possibly. But say this young kid went swimming, he came home and his ears inflamed red, and the thing about it is inflamed red, it's enlarged, you see the asymmetry, and it's painful to this person. What's going to soothe that pain? Anti-inflammatories may be given. Analgesics. What if you notice that the child comes home today and then you notice he's getting ready to go to school the next day and there's more inflammation? What body system is affected where there's retaining of fluid in that area? What's not draining? The lymphatic. I didn't say this in lecture, but the lymphatic system is not affected, where you're not having the drainage of the waste products through the lymphatic system. The condition is getting worse if there's more edema set in. And you mentioned all what you do, analgesics, anti-inflammatories, rest for that person. They may have some edema that's building in that's affecting their equilibrium. Okay, let's go to otitis media. What age group is more prone to acquire this?
Babies.
Young children, why? Shorter, station 2. And usually when they have upper respiratory infection, it passes into the middle ear. So what would be a pertinent question to ask a parent if they bring a kid in with otitis media?
Are they going on the ear?
Have they had any drainage process, respiratory infection in the last week or two? Any allergies? Okay. What would the tympanic membrane look like?
Swollen.
Red. Fluid behind it. Bulging. This child goes out to play, trying to get back to feeling like a kid. And he comes in and says, "Oh, I feel so much better." But you see drainage from the ear. What happened?
Eardrum burst.
Eardrum fluid burst. They still need to be on antibiotics even though it ruptured. What if this child is with frequent reoccurring otitis media? What are they candidate for? Tubes. Post-eustachian tubes. Those tubes, once inserted, will eventually come out on their own. So that child, if they have otitis media, what might they manifest besides hearing loss? Fever, but looking at them and their mobility, what might they?
Dizzy.
Off balance.
Dizzy.
Their equilibrium is off. They may say, "I feel dizzy," like that little kid. Oh, you know, on the YouTube. Okay. Now let's move to Meniere's. It's of the inner ear, manifested by fluid buildup. The person has tinnitus. I say tinnitus. Right? What is that?
Ringing.
Ringing in the ear. They have dizziness and vertigo. What is vertigo? Dizziness. Okay, what would happen? Which one is the room spinning around?
Vertigo.
Okay. Now, so they have the ringing in the ear, they have the vertigo, dizziness, and they have nausea. Okay. This person is needing medication management. So they will need, remember, antihypertensive because of fluid buildup, diuretic, and Antivert for the dizziness, antihypertensives, diuretic, and antivert for the dizziness. What is the focus of the diet? Low sodium again.
But do you want to also give an anti-nausea?
Something for nausea. Mhm. So, what would alert you to the fact that someone is dealing with Meniere's is that they will have all those symptoms. You treat the symptoms. That's what you want to do with Meniere's. Okay, next, moving from, okay, ear. It's the acoustic nerve. You may know it by another one, another term, but the acoustic nerve that is associated with ear, auditory acuity. What did we say in regards to irrigating the ear? If I had some kid that did a pea in my ear, would you try to irrigate my ear? No. What's going to happen? It'll push it further, and that water will absorb, the pea will absorb the water, and thus cause decreased hearing. Now let's go to seizures. Headaches will not be as good, but you guys kind of know. But migraines, if it was on the test, how would you differentiate a migraine from a stress headache? What might the migraine person have?
Vision,
Vision, what is that called when they have something before? An aura. Let's talk about seizures. There was types. There was tonic, clonic, by itself, tonic, clonic, and then there was tonic clonic, which I demonstrated up here, tonic clonic. The tonic is when they're stiff. The other one is clonic. They're in a convulsive state. Okay. Then you also had others, but you had absence. What did the absence person look like? They're absent. Yeah, that's a good idea. Lights are on, nobody's home. All right. What do you want to do with any seizure activity of a patient? Say they're hospitalized. What is your role as a nurse?
Airway.
Protect the airway, protect the head. You want to keep them from harm. What will you do if they start to having an emesis? Or they get suicide? You don't want them to aspirate. You want to prevent constricting them or restraining them. Medication you're going to give to them. What are they? Anticonvulsants, Dilantin and Tegretol. The side effect of Dilantin is hyperplasia of the gums. So what are you going to do as a nurse if they have that? Treat with oral care. Tegretol and Dilantin, you need to teach the patient that they'll have serial, meaning repetitive, every 3 months or something like that. You want to look at the therapeutic levels of that drug, because the therapeutic and the toxic levels, the parameters are so narrow. Dilantin heightens the seizure threshold. That means when you heighten the seizure threshold, that means they don't go into a seizure as readily. That's the purpose of Dilantin and Tegretol. It keeps the person from going into seizures, so it heightens the seizure threshold. Along with the Dilantin and Tegretol, you may give, if they go into a seizure, what medication to bring them out of the seizure and slow them down.
Ativan.
Ativan, maybe given IV. What do you the word is never, want to do while they're in the seizure. Relative to the mouth.
Put
Don't
anything.
put anything in the mouth. Parkinson, what neurotransmitter are they lacking? Dopamine. And the reason why they lack that dopamine, there's too much,
Acetylcholine.
they lack dopamine. And the thing is, it's a neurotransmitter. So what will they look like? What's going to happen with them? Tremors, difficulty in walking. They may have that mass base, remember the picture, and their safety risk is stated. So we're going to give them dopamine derivatives to increase their activity level. But there's side effects to those medications. What are they? Drooling, where they can't control their secretions, so you give them anticholinergics. So there's side effects from those anticholinergics. What is that? You can't pee, lose spit. So you're going to promote those things that they won't get into that situation. So if they're on an anticholinergic, you want to hydrate them. You want to promote bowel elimination. You promote oral care. Alzheimer's. Can it be diagnosed while we're in the living? Generally, it's a death. Alzheimer's is a type of dementia. Remember we said it could be called sundowners. Generally, their memory is it remote, or their acute memory is it more remote or current? You said it. They can remember remotely, but if you tell them to do something current right now, their little brain waves is not communicating.
What does that mean? That their short-term memory is gone, but they have long-term memory?
Yes. So, they may not remember family members, grandkids. So what are you going to do? You bring pictures to try to orient them?
Don't they have problems with time and space? Too?
Time and space. They may tell you, oh, I'm at that group home, but then they tell you, I'm in the kitchen, and here they're in their bed. They have misappropriation of what they need to be dressed in, misappropriation. They may think this is a cone. They love to roam in the middle and end stages. They love to roam. So what do you need to promote so they're not roaming at night? Rest. You want them to rest. If they're in the hospital, there's a bed alarm.
Restraint.
Yeah.
No, that's the last resort. So you want to promote rest for these individuals during the day. What's their diet? Same as Parkinson's would be. Finger foods, easily chewed and digested. With Parkinson's and Alzheimer's, there's high risk for a caregiver role strain, so we're going to promote respite care or suggest that they avail them of places where they can get respite care. Patient asks you, or family member asks you, can we diagnose this person as Alzheimer's? The doctor says they have Alzheimer's. Is there a test that we can check it? No, it's generally on autopsy. What do you need to do to assist the patient in keeping their mind active? Reading. Huh? Yeah, a set schedule. Yeah, keep your mind active. Okay, let's go to CVA. CVA can be, there's two types, ischemic and hemorrhagic. Generally, ischemic stroke is usually associated with what disorder? What
Hypertension.
perpetrated? Some type of confusion, right? So atherosclerosis is one. Plaque buildup, fatty plaque in the blood vessels. Relative to stroke, what are some modifiable things they would do to prevent that stroke? Lifestyle changes like what? Low cholesterol diet, what'd you say? Stop smoking, weight loss. If they're on medications like your antiplatelets, or they're on Coumadin because they have another problem going on, they need to stay on their medication. What group of meds would dissolve the clot if it was ischemic?
Trembling.
If I said a person had receptive aphasia, they can't understand what you're saying, but you still need to be attuned to their nonverbals and assist them in that process. If they had expressive aphasia, what's going on?
Can't speak.
Okay, they know what you're saying, but they can't either enunciate or even verbalize back to you. So receptive, they can receive what you're saying. Expressive, they can't say back to you. They know what's going on, but it's hard for them to say back. If they have expressive aphasia, they can get some words out. What do you need to promote as a nurse so that you can communicate? If they can write.
Or a yes, no sign.
Give them time to enunciate. Give them time to talk. Again, look at their nonverbal cues. If someone had hemianopsia, what sense is affected?
Vision.
Vision. If I had hemianopsia on my right side, how would you adjust my care?
Make sure that
You want to approach me on the unaffected side, right? If it's the right side, you would approach me on the left. Okay, spinal cord injury. Age group and gender most associated with spinal cord injury. Males, late teens to middle age. Okay, spinal cord injury. I have a spinal cord injury of C3, C4. What body system is acutely assessed at this time?
Respiration.
I have a spinal cord injury of lumbar, of my sacrolumbar region. What will you know that you'll be promoting the care with more readily?
Elimination.
Elimination. Okay, and you'll do those same things that we did with anybody who had elimination problems. You might have intermittent calf. You might have to promote with dietary, fluid, fiber, and you still again might have to do some pressure massage if need be. This person has autonomic dysreflexia. What may have caused it? Remember autonomic?
Bladder retention.
Bladder distension, bowel distension. Bladder distension, bowel
What was
distension.
that word again?
Autonomic dysreflexia. In this condition, you would expect the person's blood pressure to go up. It's a medical emergency. What do? You remove the cause. If it is a full bladder, you catheterize it. If it's bowel, you need to help them with elimination of the bowel.
Did he say something about sex can cause that or something too?
Any type of pressure. You're in the same vicinity that for elimination as you are with sex, yeah. So it can affect, okay. But predominantly it's a full bowel, full bladder.
Is this the vagal response, or is that?
It's just a response because the nerve innervation isn't there, they don't sense the pressure build up, and then this is the body's way of saying something's wrong.
You take care of the problems that cause it.
Spinal cord injury also, what is the medication given to decrease the inflammation? Solumental. Okay, MG. What is the medication used to determine if they have MG? Begins with a T.
T.
Tensilon. If I have a negative Tensilon, do I have MG?
No.
No. If I have a positive Tensilon test, they've injected the Tensilon through the IV, and my muscular movement gets better, I have MG. Because the medication reversed what was occurring. It is autoimmune. Myasthenia gravis is autoimmune. I told you I wouldn't go into the crises, but if a person took too much of the medications to, say they took too much of their anticholinergic medication. They took too much of it. Remember, in this case, what is missing with MG? What neurotransmitter? Acetylcholine. Okay? There's not enough acetylcholine, or the receptor sites are blocked, or there's too much anticholinesterase. Cholinesterase, excuse me. Let me say that again. There's not enough acetylcholine. The receptor areas are blocked from the acetylcholine, or there's too much cholinesterase. Remember, when your muscle is activated, that's acetylcholine. When it relaxes, that's cholinesterase. So we give these people anticholinesterase medicine. If they take too much medication, they can go into cholinergic crisis. If they don't take enough of their Tensilon or Mestinon, they can go into a myasthenic crisis. I'm not testing you on the crisis. Okay. Bell's palsy, which cranial nerve? 7. What is that called? What cranial nerve is it?
Facial.
Facial. What would you see in the patient? Usually you have paralysis on one side. What do you need to promote with this person if they have Bell's palsy? Since it affects the eye, it's eye drops. And what do you need to do if there's any drooling? Oral care. It's self-limiting. However, they can get it again. Okay, trigeminal neuralgia. Which cranial nerve? The 5th nerve. Okay. What are these people considered? Severe
Pain.
Okay. They have difficulty chewing. Anything that activates the mouth, chewing, swallowing, any of that, a lot of that nerve. This person did not respond well to the medication management, which would have been your Dilatin or your Tegretol or your Valium. So they had a severance of the nerve. You get them post-op, and there's asymmetry of the face. Do you need to be concerned?
No.
MS, another autoimmune disorder. Differentiate for me the difference between MS and Lou Gehrig's. Which one has visual problems?
MS.
MS.
Okay, which one has tremors?
Both.
Okay, where are the tremors in MS?
Hands.
And the tremors in MS?
Hands.
Hands.
It could be hand, okay. Lou Gehrig's is hands, arms, and legs. MS, did I say that? Lou Gehrig, yes. Okay, MS, the tremors can be in those areas also, but usually it's the lower extremity. And they have spasticity. Spasticity is with MS. Which one can have relapsing and remitting?
MS.
Which one is a constant degradation?
Lou Gehrig's.
Okay. What usually causes these people to die with Lou Gehrig's?
Respiratory.
Respiratory failure. Both are sclerotic type changes where there's not nerve innervation. Okay. With Lou Gehrig's, do the muscles become stiff or are they atrophied?
Atrophy.
Any of these nerve disorders, they have dysphagia that can occur, so you know what dietary changes you need to do. You need soft foods. Okay. What disorder has to do with an infection, usually respiratory infection, 2 weeks prior? Guillain-Barré. Okay. Is it self-limiting?
Yes.
Yes.
But it may last
For a
up
whole
to
year.
a year. But it gets better. So if a patient says to you, will I die from this? Generally not. It's self-limiting, but tell the person that they need to gradually increase their activity. It's not the time to go full force at work. Okay. Side effects of taking Dilantin. Predominantly, you notice over time, what will happen to the oral cavity? The
Gums.
Hyperplasia, and you do the oral care. Someone has, this disorder is associated with ptosis. We have Bell's palsy, and we also have where there could be asymmetry of the face. Usually Bell's palsy. Okay. If I said someone was hemiplegic, what would that mean to you? What is hemiplegia?
Half the body.
Half of the body. What if they're paralyzed? Okay, so if I said someone has okay, someone has spinal cord injury, and they have a partial severed, so they have paralysis on the side. That's hemiplegia. If it is a spinal cord injury and they have muscle movement and sensation above the waist, but below the waist, there's not the nerve. They don't have the innervation of the nerve. That's paralysis. Think of it this way when you ask these questions. If you're asking a question. If it asks you on the test what you would do first relative to any of these nerve disorders, if the person can manifest respiratory impairment as of this disorder, you want to manage the respiratory status first. If I said a person has a spinal cord injury that is at the lumbar sacral area, it wouldn't be respiratory, it would be what? Elimination function. It's always the lower, below the level of injury. The higher it is, the more this functions. The more caudal or lower, like at the lumbar sacral area, you're going to have elimination. There will be 5 men. You know this man, the man. It's the same as you've ever had. Again, don't spend a lot of time on CBA or headaches, I tell you right now. You will have questions on eye and ear of the disorders on thyroid. You will have questions on Parkinson, Alzheimer's, and spinal cord. You will have MG, you will have MS, you will have Lou Gehrig's, and you'll have Guillain-Barré. And you know the difference between the two spinal, or the cranial nerves. Number 5 is trigeminal neuralgia. And you know if they're not responding to medication management, the severance is the last resort. Bell's palsy is self-limiting, and the person, what would be given for the inflammation there? Corticosteroid. If a person is taking any degree of corticosteroid, you would have them avoid what?
Crowds.
Greg said it earlier. If they're autoimmune, if your corticosteroids decrease the autoimmune, you don't want them in crowds. You want them to avoid any transmission of infective process, so you would tell them to limit crowds. They need to take the whole dose of the medication. If they feel better, they need to take what is ordered. I will be there Thursday. Professor Bethune will be here Thursday. If anyone needs more specialized time.
Where are we gonna do it at?
Yeah, this room, the conference room.